Hi everyone, we're going to talk about drugs for pain. So pain is part of your assessment, right? Which is the A part of ABPI, which is the nursing process. And so a lot of times we don't need to necessarily ask somebody if they're in pain. We know based on their condition or what they just had done, maybe a procedure or an accident they were in. But we do need to think about how we know if someone is in pain. And if you think about it, you can tell by looking at a friend, right, who's in pain, that they're not feeling good. So facial expressions, maybe how they're walking, the things they say, um, their behavior, maybe they're not eating, maybe they're not sleeping, maybe they're holding a body part that hurts. Um, as nurses, we also need to be a little more tuned into it because sometimes our patients are in pain and they don't want to tell us, or culturally or developmentally, they can't tell us, right? How can a 3-month-old tell you that they're in pain? So, and you'll learn more about that when you do, pediatrics and some of these other focus areas. But there's a purpose to pain. And I know it sounds really strange, but if we didn't have pain, we wouldn't know that something's wrong, right? If your big toe didn't start to hurt and ache when you have that ingrown toenail, then you would not, know that you have a problem down there. Your foot would become infected. Maybe maybe you would lose that foot. So pain is like a warning signal for us that says, hey, there's something going on and you definitely need to pay attention. And then, like I said, cultural and developmental influences. Patient may come from a culture where they don't express pain. In many countries, many developing countries, women who give childbirth, give birth, do not have access to pain medication and are also not allowed to express their pain. It's considered a sign of weakness. Or they'll tell you, save your energy for, actually birthing the baby. So you may get someone who culturally just isn't gonna tell you. And then, like I said, developmental influences, the very old, the very young. Sometimes you just have people that are just, they pride themselves on having a high pain tolerance and they don't want to deal, they don't want to deal with, they don't want to tell you that they have pain. It's funny, sometimes though, those people can kind of become martyrs. Like, they have terrible pain, but they don't want to take anything, but they want you to acknowledge that they're in pain. So that's always an interesting situation. And then acute versus chronic pain. So something like, hitting my finger with a hammer, which hurts right here and right now, versus maybe arthritis or something that I've had for a long time that I have to deal with that causes chronic ongoing pain. A lot of people suffer with chronic back or joint pain. So those two kinds of pain are very different. They're treated very differently. And what works for acute usually does not work for chronic. So I'll just say that in light of what we're going to talk about with opioids. And then there are tons of non-pharmacologic pain management techniques, right? So to think about what those are. There's all kinds of things that we can do from a non-pharmacologic standpoint. And then just so you know, you'll hear the term analgesics, that these drugs are analgesics. And again, an means against, and algesia means pain. And so analgesics are pain relievers. That's the Latin definition. So mechanisms of pain. There's two main types of pain. There's nociceptive pain and there's neuropathic pain. Nociceptive nociceptive has to do with tissue pain or visceral pain. Visceral meaning like your viscera, your organs, right? So it could be as simple as a burn or a cut or a scrape or hangnail or, cold sore in your mouth or, toothache. Or it could be something like, a deep pain in an organ because it's full of cancer, or you have appendicitis, or you could have muscle pain. You could have severe muscle pain. That's nociceptive pain. That's tissue related or organ related. That's very different than neuropathic pain. Neuropathic pain usually has to do with injuries of the nerve due to chemicals. There are some chemotherapies that can cause a lot of neuropathic pain, injury. So maybe you were electrocuted or had a crush injury of some sort. Amputation can cause neuropathic pain, and you've probably heard about phantom limb pain, and that is another type of neuropathic pain. And then compression. The best example I have for this that's probably relatable is if you have your arm in a cast and you start getting, the cast is too tight. You can have both nerve pain and you can have tissue damage. So it's kind of a combination of both. But think again, like maybe an injury, a crush injury, or something where a hand or leg or foot or something was pinned or trapped. So, and then I just want you to know about this stuff called substance P. Substance P is a neurotransmitter, and we know what neurotransmitters are because we just talked about that in the autonomic nervous system. And it determines whether the pain signal coming from the body is going to be sent to the brain. So substance P is sort of like a gate opener almost, and it can be impacted and affected by other neurotransmitters in the central nervous system. So we have our own endogenous, meaning, or chemicals that just live inside of us that may lessen pain. Things like our own opioids, believe it or not, endorphins, right? So we have our own pain management system, but sometimes we need a little help from our pharmaceutical friends. Okay, physiologic targets for pain medication. So why do pain meds work? How do they get in there and make a difference? And there are a number of different ways that pain medications can work. So if you think about that, that means there's a number of different drugs with different mechanisms of action. And so sometimes when we're treating pain, we can't just use a single approach. We have to actually use multiple types of drugs with different mechanisms of action in order to address the pain. But bottom line is nerve impulses are sent from the peripheral tissues to the brain via the spinal cord, right? Neurotransmitters going across all those little axons and synapses. And eventually the brain receives the message and then sends out a signal to our motor neurons, usually like, ouch, that hurts, causes us to avoid pain, like pulling our hand off the hot stove or the hot pan. And that happens like in a nanosecond. It's just, pain, pull back, immediate, almost immediate. So two main areas where medications work, probably the most common medications for pain, is the central nervous system and right at the tissues or target organs where the pain occurs. So if you look at our pain pathways, you'll see here that, there's something happening in the skin, right? Let's just say this is our sensory neuron. Skin's our example. And the signal goes in through the spinal cord and then up into the brain where it's sent to the sensory cortex, and it says, ooh, something happened. And the way that you feel this pain, again, is, let's say you have arthritis pain. So the red arrows show the signal going up to the spinal cord, up into the brain, right? And then this pain can affect not only our sensations, but it can affect our emotions and it can affect our thoughts. And if you know someone who's dealt with chronic pain or debilitating pain, like cancer pain or something like that, it can be just all encompassing, and it can just take someone who's vibrant and active and, really engaged with the world to someone who's quiet, withdrawn, in bed, in a fetal position, can't talk, can't engage. Any of you who, when you get to maternity, you tell me how effective it is to have a conversation with a mom who's in labor, right? They are not going to be talking to you very much. They might tell you how much it hurts, but really all their energy, effort, emotions, thoughts are going toward dealing with that pain. Makes you want to have a baby, huh? So we also need to think about complementary and alternative management of pain, CAM. And I would also say that these are, this fits into the realm of non-pharmacologic pain. So things like acupuncture, art or music therapy, biofeedback, maybe a hot or cold pack, maybe some meditation or music, or there's aromatherapy. There's TENS, which is transcutaneous nerve stimulation. I didn't get that quite right. Anyway, I'll think of what that stands for. But TENS, it's used in a lot by physical therapists. And then non-traditional medications, right? Like we may use like an antidepressant as part of a regimen for dealing with chronic pain. Because again, pain isn't just one thing in somebody who has chronic pain. Now, the other thing that's not on here is are things that are not necessarily approved for pain. So you may have people who take supplements, people who smoke or ingest cannabis. So people who do lots of kind of unconventional things to treat pain. And what I would say to you is the more severe and the longer the patients have the pain, the more likely they are to turn to these complementary and alternative management methods because traditional things have not worked for them. And so people get a little bit more interested in trying other things other than sort of what the medical model of our medical system brings, which is, our medical model is that you have a problem and we fix it, rather than we want to prevent problems so that you don't have a problem, so that we don't have to fix it. Okay, so dosing of pain medication. And again, this is just kind of a high overview of pain and then some of the classes of pain medication that we're going to be talking about. But dosing of pain medication is very interesting. And in fact, there are people who make their entire career out of managing pain. There are pain specialists, physicians, nurse practitioners. There are pain clinics. So pain is very complex. Dosing of pain medication is done in a few kind of standard ways, though. And I'm sure this doesn't cover everything, but it covers a lot of what you're going to see, especially in the acute care setting. So around the clock, ATC. Around the clock is used for severe or like immediate post-op pain. And the goal of giving meds around the clock is to sort of achieve a steady state of pain control. What you don't want is you don't want the patient to be in agony, then you give them pain medicine, and that works for a while, and then it wears off, and then they call you again only when they're in agony. That is a bad way to manage pain. The best way to manage pain is to stay on top of it and to anticipate it and to treat what we know is coming. So around the clock works well for that. Maybe your order is something like morphine, 10 milligrams every 4 hours for acute post-op pain. And that might be the order that's in place for the first day or two if somebody's out of surgery. Now, the nurse can always look at that and choose not to give it if we feel that the patient, A, shouldn't get it for some reason. Maybe their respirations are 4 from their last dose of pain medication, and we really should not be giving them more. Or maybe the patient's being able to go longer than 4 hours. The pain medicine is taking them longer through that pain period. So sometimes, it'll be ordered every 4, and your patient at 4 hours is like, no, I'm doing okay. I actually feel pretty good. So then you put it off to 5 hours or 6 hours. And then it's time to let the provider know that maybe we need to go to a different schedule for pain management. When people are on around-the-clock medication, they also need to have rescue meds. Rescue meds are just additional pain meds that should be available for pain that sort of exceeds what's being managed by the around-the-clock dosing. And again, let me give you an example. Let's say the patient had surgery 24 hours ago. They've been in bed, they've been doing fine every 4 hours, but then the physical therapist comes in and says, guess what? It's time to get up and walk around. And they got their last pain med 2 hours ago, and they get up and they walk around. By the time they get back in bed, they are just in agony. And now, technically, you can't give them any more pain meds for another hour or two. If you have a rescue med ordered, which would be PRN, meaning as needed, then you should be able to maybe give them something to sort of cover that pain that occurred as a result of getting out of bed. PRN dosing, which just means as needed. And by the way, PRN always comes with more instructions. It's not just PRN. It's like PRN pain greater than 5, or PRN pain exceeded by, whatever. So it'll give you some kind of parameter, and it will usually tell you how often you can give it PRN. So PRN means that the nurse is deciding that the patient needs the medication, and the nurse is making a judgment call about when to give that medication. So sometimes this will happen, like maybe a patient went for a procedure, and I've had patients go down for like a central line placement. They come back up, and sometimes, they're a little achy and they seem okay. Sometimes they're really uncomfortable and they need something for the next, 12 to 24 hours. Also, we might use multiple medications to, again, maximize pain relief. And I mentioned this earlier, that we use things with different mechanisms of action. When my son has had his wisdom teeth taken out, because most dentists are trying to avoid opioids now, he went on an alternating ibuprofen, Tylenol regimen for the first 2 days. And that worked really well for him, actually, and his pain was very well controlled. So as I just mentioned, we really want to work toward avoiding, if possible, or reducing opioid use earlier in recovery from an injury. Now, this is not to say that, post-op, the bowel resection, where they cut out, 10 feet of someone's bowel, that we say, oh, no, we want to make sure that you don't get addicted. We're not going to give you any opioids. That's not true. But what we don't want is 10 days out from that surgery, the patient to still be on the same level of medication and types of medication that they were on 10 days earlier. Really, the body begins to heal, and we need to be transitioning patients from medications designed for severe or moderate pain down to medications that are more for mild to moderate pain. And then last but not least is PCA. It's called patient-controlled analgesia. It's like giving your patient a button to dispense medicine when they need it. And that sounds like kind of a crazy idea, except that we program our pumps so that patients can't overdose. They could, they could push the button 57 times, but maybe it's set to give 3 doses 10 minutes apart every hour, right? So usually the PCA has some kind of low level, drug going all the time, like morphine, and or it could be Dilaudid or some of these other heavy duty opioids. And then if the patient feels pain, they can push the button. Again, pretty well controlled. It's very important that the patient does the pushing and not a proxy, meaning you can't have the husband or the sister or the mom pushing the button, because one thing we know about PCAs is people know what they can handle and what they can't, even if they don't know it cognitively. And people are pretty good about not giving themselves too much versus, maybe you have a patient that's in bed and they groan a little bit and the mom or somebody goes over and pushes the button. Well, maybe the patient was just groaning because they moved a little bit, but their pain's fine. But now you just gave them another dose of meds. So we have to be really careful about that. Opioids. So we're going to talk about a couple of different classes of pain meds here. I'm going to talk about them at a high level, and then when we get to our prototypes, which will happen later, then we'll talk about the specifics. So opioids, in case you didn't know, that they actually come from the seeds, the unripe seeds of the poppy plant. And so that's where we get opium, right, which people smoked and traded long ago. And this is where our opioids come from. And opioids can be either natural or synthetic morphine-like substance, and they are for moderate to severe pain. We do not give opioids for a hangnail or, a very minor burn, something like that. So, and then they are considered narcotic substances because they induce sleep or a numb feeling. And if you think of the word narcotic, narco, right? We think of that now with probably the television show Narcos, but narco has to do with sleep. And so narcolepsy is, people who have this sleep and numbness, and they kind of have it's almost like a seizure or an event where they fall asleep. So that's where narcotic comes from. And then opioid refers to any substance with opiate-like activity. So anything that's kind of morphine-like is going to be called an opioid. Their mechanism of action is that they exert all of their activity in the CNS, on the brain, and most often on the kappa and the mu receptors. So again, don't need for you to necessarily know kappa and mu, but opioids are not working out at the source of pain. They're not working at the incision that the patient just had. They're working up in the brain, and they're telling the brain, hey, you don't feel that incision down there. Don't worry about it. It's all good. So there's different types of opioids. There's agonists. Agonists are, opioids that come in and they click right into the receptors on those kappa and mu's, and they activate that opioid effect, right? So pain relief, sedation, numbness, euphoria. It's great. Opioid antagonists block those kappa and mu receptors. So they kind of sit on top of those receptors, almost like locking the door and saying, nope, sorry, you can't come in. And so those drugs keep agonists or opioids from clicking on those receptors and you have this antagonistic effect. So Narcan or naloxone is what we tend to think of for that. And then you have mixed agonist antagonists. And I only mention this, you're not going to learn a prototype for this, but I only mention this because there are some older pain meds that are sometimes used for patients that, kappa is being maybe stimulated, but a mu's being blocked. So it's kind of an interesting thing, but they can still produce pain relief. Okay. But it's called a mixed agonist antagonist. We are mostly going to be dealing with agonists. We'll only talk about antagonists as we talk about the use of naloxone for reversing the effects of opioids. So what are the effects of opioid agonists? You absolutely must know these because they're such a hallmark of opioid therapy, and it's many of the effects are things that are managed by nurses. So analgesia, that's awesome, right? You just had a surgery, you had your knee done, you had your ACL fixed. You are going to be so happy that you have this med, right? But it can cause decreased GI motility. A lot of people who get morphine end up feeling like nauseated. Some will actually even vomit. So you might be giving morphine, but you might also be giving an anti-nausea medicine. It can cause euphoria. Again, just I think that combination of the relief of pain and then what the med does to the brain just can cause people to feel good. And that's why we end up having people who get addicted to opioids, one of the reasons. Physical dependence. So let me be clear about this. Physical dependence is different than abuse or addiction. And we'll talk about this a little more later. But it has more to do with the physiologic kind of getting used to having the drug around that your body sort of likes. It's like, oh, cool. I've got this stuff coming in. I don't really need to make my own endorphins or opioids. And then respiratory depression. This is probably the big effect that people think about when it comes to opioids is when you give opioids, you definitely want to watch your patient for respiratory depression. It can also cause sedation, which may or may not be bad, but you don't want sedation that's so deep that A, they stop breathing, or B, they're completely unresponsive to you. So sedation where they fall asleep, no problem, but that can be an issue. And then urinary retention is another thing that opioids can lead to as well. So post-operative patients who, already have issues with urinary retention just because of the anesthesia they get, then we give them morphine or some other opioid for pain, and sometimes we get people who can't empty their bladders. Okay, so what about abuse or concern about addiction? Well, that's fair. We have had an opioid crisis in our country, and if you have not watched The Pharmacist, I believe you can watch it on one of the streaming providers that's out there. You should watch it. But all opioids do have the potential to cause physical and psychological dependence. They do. And, you'll hear patients say, oh, I don't want to get addicted. I'm not going to take any of this. And, we need to have a discussion with them about that. But let me define some terms here so that we can kind of get a handle on what we mean by abuse or addiction. Okay. So tolerance is related to the physical dependence. Tolerance says that over time, our brain adapts to the continuous presence of the drug. And in order to get the same effect, meaning the same level of pain relief, you have to give higher and higher doses. And the best example I can give of this is someone who maybe is receiving palliative care for cancer and they have pain and they've been placed on maybe something like morphine or Dilaudid, they're getting it continuously. You'll find that over time, these patients need more and more of the drug, not because they're addicted, but because they're developing tolerance. And we cannot achieve pain control for them without increasing their dose. The other issue, so that's tolerance, and we know that happens. And another example of that, just to give you another sort of when could this happen, is think about someone who's been in the ICU maybe for 3 or 4 weeks, who's been sedated due to maybe a very serious illness or injury. They are to be sedated. They are placed on opioids. And we can't just stop those abruptly. Our body has gotten used to, the patient's body has gotten used to getting the medication at a certain level for a long period of time. And it takes a while for the body to say, oh, I'm not getting as much. I need to make some of my own stuff. So when we move people from ICU settings to, just like an acute care floor, a general med surge floor, a lot of times you'll see that they're on a transitional drug. Oftentimes that drug is methadone. And methadone sort of helps them with getting off the drug, but not giving them the euphoria, but it meets that physical dependence need. And then we can slowly decrease their methadone dose over time. So you'll see people on a methadone taper. I mean, I've seen babies on methadone tapers. So that getting used to having a drug and then, just all of a sudden withdrawing the source, right? If you stop giving it abruptly, you're going to have issues. Abuse means that it's the drug's being used inconsistent with medical norms. So you had your wisdom teeth taken out. You were given some pain medicine. And now it's been 5 weeks. Your teeth are all healed. You're just having a crappy day. You go into your medicine cabinet, take one of those, check out, go to sleep, have a little euphoria, even though you don't have pain. That's abuse. That is using the drug for something that it's not intended for. Addiction is compulsive use of chemical substances despite negative consequences. I want you to think of, meth users and other people who basically their whole lives have fallen apart, right? They've broken all their relationships with their family. Maybe their kids have been taken from their home. These are people who are addicted and really for whom nothing but the drug matters. And the fact that they lost their job or their car or their kids or their relationships with people, that's secondary to getting the drug. So that's addiction. And that does not happen with 3 doses of morphine in the hospital after surgery. So that's one thing I can say in terms of sort of having a conversation with patients that, the goal of using opioids, at least in an acute care setting, is usually to give them only as long as they're needed, and then to transition patients to a more appropriate drug for the level of pain that they have. And like I said, abrupt withdrawal can happen in cases of abuse or long-term use. Abuse only if it is long-term, and then unpleasant symptoms lasting up to 7 days. So withdrawal can be rough. So you don't want anybody to go cold turkey if possible, which just means cutting off the drug and not doing anything except having them just sort of sweat through it. Gradual recommendation is really highly recommended. Okay. Opioid antagonists. Now, these are drugs that compete with opioids for receptor sites. And the drug that probably comes to mind is Narcan. It's been made a lot more public due to the opioid crisis. So now we have a lot of people in the community that have this drug in their possession and can use it if they come across someone who appears to be overdosed. It's used to reverse the severe symptoms of opioid intoxication, such as sedation or respiratory depression. The thing about opioid antagonists is they compete for a place at the table at those kappa and mu receptors. They compete for that, and once they're there, they are very good at blocking the drug from the opioid from having its effect. So remember, drugs don't just go and sit on receptors. They sit on receptors so they can get inside of cells. So if all of a sudden now you have a competitor that basically locks the door so that the opioid can't get in the cell, that's going to very quickly reverse the effects of the opioid, and which could be very, very good for someone who's not breathing or severely sedated. However, just be prepared that if your patient's in pain, let's say they just got too much medication or they reacted to it, they're much more sensitive to it than you thought, and they're breathing at, 4 respirations per minute, then we definitely want to be prepared to give Narcan, but be prepared that their pain is going to, be right there. And it can be life-saving for those who've overdosed, but not always. It doesn't reverse all of the damage that's been done by not breathing for the last 5 or 6 minutes, right? And so sometimes we can use it, but it doesn't work. Non-opioid analgesics, these are now kind of more the drugs that we're used to. Probably many of you have these in your apartments or dorms. NSAIDS are the biggest class, non-steroidal anti-inflammatory drugs. And they're very common. Now, not all non-opioid drugs are anti-inflammatory, and the big one that I want you to know is acetaminophen. Acetaminophen will sometimes get thrown into the NSAID category, but technically it is not an NSAID because it does nothing for inflammation. It works on the same kind of systems, but it works in the brain, which makes it different. So anyway, just want to sort of point that out, that acetaminophen is technically not an NSAID. And we'll talk about that more. Most commonly, these are used for analgesia, but work really well to treat fever and inflammation, which we'll talk about in another lecture. Examples of non-opioid analgesics or NSAIDs are aspirin and ibuprofen. Both are excellent for pain, fever, inflammation, easily purchased over the counter, easy to take, fairly well tolerated. So yeah, they're the drug category of choice for mild to moderate pain, especially pain associated with inflammation. Now, if you have a headache and you don't have any inflammation and you want to take Tylenol, no problem. Or you have inflammation and you want to take Tylenol to deal with the pain. It may address the pain, but it's not going to do anything for the underlying inflammation. Okay, I hope that wasn't too confusing. We'll talk about this more in class. NSAIDs. Okay, so their mechanism of action is they inhibit COX. There's COX-1 and there's COX-2. And COX is cyclooxygenase, and anything that ends in ACE, A-S-E, is an enzyme. So it's an enzyme responsible for prostaglandin formation. And prostaglandins are known causes of inflammation. Okay, there's other things too. There's like bradykinins and other inflammatory markers, but we're not going to talk about those right now. We're mostly talking about prostaglandin inhibition. So let's say there's tissue damage and it causes the release of chemical mediators, specifically prostaglandins. Well, prostaglandins are formed by these COX-1 and COX-2 enzymes. And we'll talk about this more in class, but COX-1 leads to prostaglandin formation and platelet aggregation, okay? COX-2 leads to prostaglandin formation that causes pain and inflammation. So this COX-1, it kind of has actually like a good thing in it, sort of like the good with the bad. Bad is this, but the good is this. And so, if you inhibit platelet aggregation, then you're more likely to have bleeding issues. Well, that can be bad if you have like an ulcer and you're bleeding in your stomach, but it can be good if you have, say, coronary, not coronary, you have cardiovascular disease, right? You have vessel disease, and having platelets less sticky, less able to aggregate is good because it prevents clot formation. So we'll talk about this more. Good COX, bad COX is kind of how I label these. COX-1 is good, COX-2 is bad. And it'd be really nice if we could just block one of these, but unfortunately these drugs block both. And so while it's great that you get the effect of prostaglandin inhibition, unfortunately you also are going to have this lack of platelet aggregation as well. So most NSAIDs are sold over the counter, ibuprofen and aspirin, and like I said, they block both COX-1 and COX-2. They are not selective. And they're relatively safe, but not for everyone. I just gave you an example of somebody who shouldn't get it, and that is somebody who has like severe peptic ulcer disease with a bleeding ulcer, because these are going to make them bleed. Another person who should not get NSAIDs is cancer patients. Most cancer patients who are undergoing treatment have platelet issues due to the effect of chemotherapy on their bone marrow, and they don't have very many platelets. So the few platelets that they do have, they want them to work. So you don't want to inhibit platelet aggregation in those patients. So for the most part, we don't give NSAIDs to cancer patients. We do give Tylenol though, because remember, Tylenol does not have this effect. Okay, this is from your text. This is a figure in your book, and I'm totally lame and did not get the figure off of the book electronic site. I just took a picture of it. So anyway, but this is right out of your book, and it's in the chapter on control of pain. And I think this is a great picture because what it basically says is, hey, you got the nail in the bottom of your foot, right? And as a result of that tissue damage, there's arachidonic acid that is released. Whoops. My apologies. And then from there, you have COX-1 and COX-2 activated. You have prostaglandins made, pain and inflammation. Okay. So if we block right here, we use a non-selective COX inhibitor, aspirin, ibuprofen, and NSAID, then we can block some of that pain and inflammation, which is pretty cool. I also think it's really cool that with that nail in your foot, it shows how pyrogens are not related to pirates. They are things that cause your fever to go up, right? Pyro, like fire, pyromaniac, somebody who likes to set fires. So when you see pyro, you need to think fever or hot. And so it shows how those pyrogens are activated, histamine's activated, which causes, histamine in your bloodstream, and that goes up to your brain, and that's how you get a fever. So I think that's really cool. But anyway, just consider these questions. How do they help with fever, and how do they help with pain? Because these drugs block both COX-1 and COX-2, there are side effects. So this is where I've said already that we have to take the good with the bad, right? The benefits hopefully outweigh the risks for most patients. But there are some patients for whom it won't outweigh the risks, and we shouldn't give them to them. So because these drugs block COX-1 and COX-2, one of the things it can do is it can also cause GI irritation, including the formation of peptic ulcers and bleeding. That COX One also has some GI protective effects. And when we block it, it blocks like mucus production and other things in the gastric lining that keep our stomach happy and healthy. And so people who take a lot of ibuprofen can end up having peptic ulcer just from that. And let me tell you, it's a thing. It's out there. We have a lot of people in our public who come in with GI problems, and they will tell you, oh yeah, I take this every day. I take it for my arthritis, or I take it for my aches and pains. And you find out that over time it has caused an ulcer. Decreased platelet aggregation. I've already talked about this, that it makes it easier to bleed. Now we can also use that, right? I take aspirin every day, and I take it so that, you know, I have, I'm a little bit anticoagulated, and it keeps me from forming clots because I have a heart issue. Kidney injury. So I know that we think of liver injury with Tylenol, and that's true. You need to think of kidney injury with NSAIDs. Okay, so ibuprofen, aspirin, kidney injury. So I have to be careful with that. And then anaphylaxis. Some people anaphylax to aspirin, and so it's just sort of a known bad actor that way. So you want to make sure that if your patient has allergies, that you know what the allergies are too, and what that allergic reaction is. But if someone hasn't had aspirin for a really long time and you're giving them a dose, you kind of want to be on the lookout for this. Hopefully it won't happen, but you know, it's a possibility. And then, like I said, these side effects can be used therapeutically, right? Aspirin can be used to prevent clot formation. There's this old saying, an aspirin a day keeps the doctor away. And that's thought to be because of these anticoagulatory properties that, you know, think about it, people who are at risk for heart attack, are definitely, you know, or atherosclerosis are definitely going to benefit from this. And then just the anti-inflammatory properties as well. But we talked about who should not get these medications, and anyone with a bleeding issue, anybody with serious kidney disease, anyone who has anaphylaxis in the past, and anyone who is an oncology patient should not get these medications. Now we're going to get to our friend acetaminophen, also known as Tylenol, right? It exerts its effect directly within the brain, which is really interesting because our NSAIDs work at the tissue level, right? It has to do with prostaglandin formation at the site of inflammation. But these work in the brain. So they totally bypass that nociceptive tissue level. It blocks COX pathways in the brain, but not in the peripheral tissues. And its mechanism of action is really not very well understood. We know that it inhibits prostaglandin synthesis in the brain, which leads to its analgesic and its antipyretic effects. But again, because it doesn't work at the tissue level, there's no inhibition of inflammation. So this is a really important thing. If you're recommending an over-the-counter pain medication to somebody, you kind of need to know what they're taking it for, and then, you know, are they doing it for something that's related to an inflammatory condition or not? And then also what's their own background in terms of what kinds of things they can tolerate. So again, Tylenol, very well tolerated. Unfortunately, you know, we've sort of given it out like candy. The problem is that if you don't dose this correctly, it can cause significant hepatotoxicity, serious, so much so that there's a black box warning for this drug. And it needs to be dosed correctly. This is not one of those things where patients can say, oh, if 1 is good, 2 is better, or, this is the dose, but doubling it would make it better. We need to really teach our patients about being careful with Tylenol and let them know what the maximum amount that they can take during the day. And we'll talk about that when we talk about the drugs specifically. It doesn't affect the GI tract or platelet aggregation, so it's very well tolerated. But there's no effect on inflammation either. So, but it is used a lot in the oncology population because they tend to have fevers. They're immunocompromised and they get fevers. And so we treat most of those with Tylenol, not ibuprofen or aspirin. Okay, let's transition to headaches and then we will be done. So headache pain, there's 2 main types. There's tension headaches and migraine headaches. And my guess is that you've had either one or both of these at some point. Tension headaches usually are just muscles of the head and neck that get really tight, usually just an annoyance. These tend to respond really well to over-the-counter meds, rest, massage, those kinds of things, anything that you can do to sort of decrease tension. And then you can get headaches that are migraine headaches, and those are different. Those cause a throbbing or a pulsating pain, often preceded by an aura of some sort, either a smell or a funny taste in their mouth, or a visual, like squiggly lines in your vision, or part of your vision's gone, or you see a spot. It can also have, patients can end up getting nausea and vomiting with it. Sometimes these headaches are triggered by foods. Aspartame is a known trigger for migraines. In fact, both my husband and my son have migraine headaches related to aspartame, so they are carefully avoided. And then even your menstrual hormones, even your hormonal cycle. And if you tend to get headaches around the time of your menses, that is often related to hormones and can cause some wall banger headaches. They can be very debilitating. They can cause patients to miss school, work, really, and just miserable, right? So treatment goals for migraines are to stop the headache that's developing or that has developed, and 2, to prevent them in the future. Triptans are the drugs that have come on the scene, I'd say in the last maybe 20 years. They're great if they work for you. They don't work for everyone, but they do work for a lot of people. They're serotonin agonists. They're often effective in aborting migraines. So you can have a terrible migraine, take this medication, and within 30 minutes to an hour feel much, much, much better. Sometimes people are so nauseated and so sick from them that they can't take pills orally because they'll just vomit it back up. So it can be given intranasally or even sub-Q. So just know that there are multiple routes for it. And like I said, it doesn't work for everyone. So you may need to try alternative treatments. And we'll talk about the triptans. They have some very interesting side effects, and but again, can be very, very effective. If triptans don't work, we can go back and use a very old class of drugs called ergoalkaloids. These are actually derived from fungus, but they have a lot of unpleasant side effects. So it's sort of like, what do you want more, relief of your headache, or, to deal with these side effects. And Botox is another thing that was approved, I want to say about 6 years ago, maybe. I think it was about 6 years ago. I think it was 2014 that Botox was approved. And it works well. It gets injected into muscles, again, head and neck, in kind of known trigger points, and actually can kind of stave off headaches for a while. Sometimes people will get like Botox every 3 months. Last but not least, this is a little table that you definitely need to learn. So the question with pain meds, especially the over-the-counter pain meds, is what works for pain, what works for fever, what works for inflammation, right? So again, I think you need to learn this. So Tylenol, great for pain, great for fever, doesn't work for inflammation. Would it treat the pain from inflammation? Probably, but will it deal with the inflammation itself? No, it won't. Ibuprofen and aspirin are good for all three, but we know that ibuprofen and aspirin, because they're NSAIDs, they have there's a dark side, right? There's the bleeding side, the GI side that we need to be careful about. And then morphine, not that you would confuse it with these, but just to know that morphine is strictly for pain. So if you have a patient who's post-op and they have, terrible pain, but then they develop a fever because they're post-op, somebody cut them open with, a knife or a saw or whatever. Anytime we break the skin, we we open the possibility for infection. It's not going to treat fever. So you could give morphine and like Tylenol together, right? And then sumatriptan is only for headache pain. It is not going to treat any other kind of pain. You couldn't take it for like, a hangnail or something. And then again, we just talked about this. So I hope that's a good introduction to pain meds. Pain treatment is a big part of nursing. It's a lot of the reason why patients come in and seek care. And so getting to know pain medication is something that will serve you really well as you begin your nursing career.